So now we are going to start about fibroids. So fibroids is most common pelvic tumor in females. It is the most common benign tumor too, and it is also known as leiomyoma, which is called as hyaline change, and it is one of the smooth muscle tumors, myoma from its term, and which is originating from the myometrium. It is present inside the myometrium. It is called as intramural or interstitial fibroids. To begin with, all the fibroids, all of them initially start as intramural fibroids. So fibroid is mainly due to occurrence of estrogen and progesterone dependent tumor, and major growth of fibroid occurs in the reproductive age, that is the 30 to 40 years. After menopause, the fibroid shrinks and its development is infrequent. If the size of the fibroid increases and menopause, it points towards malignancy. Fibroid is most common in obese female who are hyperestrogenic stage, and more common in reproductive age too, as discussed above. So more common in patients with early menarche, nulliparous women, and African American females. Nulliparous, they are not even pregnant one time, and females with PCOS have increased risk of fibroids. What are the protective factors? The protective factors are smoking inhibits aromatase, thus decreasing the estrogen, and physical exercise, pregnancy, that is absent ovulation, multiparity, and breastfeeding. So now we are going to see about the effects of oral contraceptive pills and pregnancy on fibroids. In short, the fibroids, the OCPs have no effect on fibroids. So the more the female becomes pregnant, more is the anovulation, and that is a protective factor. So now we are going to talk about types of fibroids. There are mainly uterine fibroids and extrauterine fibroids. Uterine fibroids are again of three types, that is intramural within the myometrium, submucosal towards the uterine cavity, subserosal grows towards the peritoneal cavity, and then extrauterine fibroids which get lodged in cervical or broad ligament of fibroids. So here we are going to see about, this is the subserosal, intramural, submucosal, and then this is the cervical. Subserosal fibroid can be pedunculated or non-pedunculated. Broad ligament fibroid, this is an example of extrauterine fibroid. It can be of two types again, true-BL or pseudo-BL fibroid. True-BL fibroid arises from the broad ligament, and fibroid is present lateral to the ureter, whereas pseudo-BL is the one which arises from the serosa and grows into the broad ligament, and it is present medial to the ureter. Broad ligament fibroid, generally the females having broad ligament fibroid develop polycythemia because the fibroid that compresses ureter, it stimulates the release of erythropoietic factor. And coming to the FIGO classification, there are 8 varieties of fibroids. Submucous fibroids. Coming to the submucous fibroids, type 0, it is completely within the uterine cavity. Type 1, where 50%, less than 50% is in the myometrium, or more than 50% is in the uterine cavity. Type 2 is where greater than or equal to 50% is present inside the myometrium, or less than 50% in the uterine cavity. Just reverse of the type 1. And the hysteroscopic classification of submucous fibroids is Wamsteker's classification. The type 0 and type 1 can be removed hysteroscopically. The intramural fibroids account for type 3 and type 4 of FIGO classification, and subserosal come under 5, 6, 7 types, and extrauterine fibers, that is broad ligament and cervical, come under type 8. What is the presentation in a fibroid? How does the fibroid female present to us? The most common presentation is asymptomatic, that is the incidental finding, and the common symptom is menorrhagia. The most common fibroid to cause menorrhagia is, fibroids can cause dysmenorrhea but can never be the chief complaint. Most common fibroid to cause menorrhagia is cervical. Fibroids can never cause dyspareunia. Fibroids can never cause dyspareunia. Dyspareunia means painful intercourse. Benign fibroid. It indicates the fibroid is undergoing degeneration, and pedunculated subserous fibroid is called as torsion. What are the pressure symptoms? The most common cause is subserous fibroid. Fibroid, whenever there is a fibroid, there is uterus enlargement. So it causes chronic pressure, causes constipation, causes pressure on the bowels, and urinary symptoms such as urinary obstruction. Coming to urinary obstruction, whenever there is the location of the fibroid is anterior cervical, there is increased urinary frequency. Whenever the fibroid is posterior, that is cervical in position, there is urinary obstruction. And infertility, coming to infertility and recurrent abortion, most common fibroid causing infertility and recurrent abortion is submucous fibroid. The only thing to be remembered here. The structure of fibroid. So this is a basic pathology. So it is white or off-white in color, resembling the myometrium. Simple. Cut surface is rough, horrelled, and uneven broad base. There is such a broad base, and is surrounded by a pseudocapsule that is enucleated easily, and it is more vascular at the periphery. It is more vascular at the periphery and least vascular in the center. So degeneration begins from the center of fibroid. So this is called as hyaline degeneration. And the most common degeneration as discussed is hyaline degeneration. Hyaline by the term cotton candy appearance in histological staining. Least common is to occur as sarcomatous change or malignancy, leiomyosarcoma. Most common fibroid undergoing sarcomatous change is submucous, that is undergoing malignancy. Leiomyosarcoma is submucous. And the change is occurring, it becomes painful, size increases. On HP, greater than 10 mitosis per HPF, and the pseudocapsule is lost. Degeneration is more common in the center, except calcific degeneration, which is more common in the periphery. Degeneration is more common where hyaline degeneration is common in the center, except for calcific degeneration, which starts from the periphery. The maximum chance for calcific degeneration is seen in subserous fibroid. And what is a wandering fibroid? Wandering fibroid is nothing but a pedunculated subserous fibroid lost its connection with the uterus, hence the name wandering. Coming to FIGO classification of fibroids, International Federation of Gynaecology and Obstetrics. So there are again 8 varieties as discussed in the previous part. So I'll briefly discuss. There are type 0, 1, 2 varieties of submucous fibroids, type 3 and 4 of intramural, and type 5, 6, 7 subserosal. Type 8 is an extrauterine fibroid. And coming to an example where they have given type 2 by 5 is where 2 inner boundary, that is submucous fibroid, which is greater than 50% present in the intramural region. 5 outer boundary is subserosal fibroid, which is where more than 50% of its part is intramural. According to FIGO classification, hysteroscopic myomectomy can be done in type 0 and type 1 only. Coming to step W classification, where they are giving different scores such as score 0, 1 and 2 based on size of fibroid and location of fibroid. So coming to the location of fibroid, score 0 gives the upper position of the, that is location in the upper part of the uterus. Body, within the body it is 1, the score is 1, and within the lower part, that is the cervix region, it is 2. The higher the score, the chances of removal through higher the score, lesser are the chances of removal through hysteroscopic myomectomy. This means that when a fibroid which is located in the upper part has more chances of removal using hysteroscopic myomectomy. And there are also allotting scores according to the size, that is less than 2 centimeters easily removed, that is located in the upper part, 2 to 5 centimeters within the body, greater than 5 centimeters given a score of 2. The classification also includes 3 other criteria mainly. If the total score is 4, then hysteroscopic myomectomy is possible. If the score is between 4 to 6, then gonadotropin releasing hormone administration can be done by decreasing the size of fibroid followed by hysteroscopic myomectomy. If the score is more than 6, myomectomy is not possible. What are all the different investigations we have to use? Investigation of choice is ultrasonogram. The findings are: intramural fibroid is seen. It is a well-defined because of pseudocapsule, centrally located, homogeneous in appearance. Appearance is similar to that of myometrium. But for a submucous fibroid, a better investigation is saline infusion ultrasound. The features that are differentiating a submucosal fibroid from a polyp is the submucosal fibroid base is very broad and polyp has a narrow base, and also fibroid has vessels in the periphery, and the polyp has a very characteristic sign called as feeder vessel sign or bridging vessel sign. See, for a better clarification, a Doppler USG can be used. Fibroid, it is covered by pseudocapsule. Blood vessels supplying are also in the pseudocapsule. But polyp has a single vessel coming up till its center. This is called the feeder vessel sign. In the USG, subserous fibroid is arising from the uterine fundus. Here, blood vessels can be seen around the periphery of fibroid. These blood vessels are arising from the uterus and passing to the subserous fibroid. This is called as bridging vessel sign. It also differentiates between a mass arising from the uterus from a mass arising from the bowel. Again, feeder vessel sign seen in polyp has a very narrow base of attachment. See, they're showing here. Image of polyp showing feeder vessel sign. And hysteroscopic image of a submucous fibroid is where it is all white and pale in color. It has very broad base and surface vessels seen here, appreciated here. And what are the different managements of fibroid? A patient with fibroid can come for treatment for one of the following symptoms: heavy or prolonged bleeding, or either bulk symptoms such as abdominal protrusion, bladder or bowel dysfunction, or reproductive dysfunction such as infertility, and pain. Pain in fibroid is very uncommon, but can either be painful menstruation or non-menstrual pain. Causes include infection, or in pregnant females it is due to red degeneration, or fibroid has undergone malignant transformation or torsion of a pedunculated fibroid, which is very rare. And the pre-treatment evaluation is investigation of choice is USG. In case of submucous fibroid, a saline infusion sonography can be done as discussed, and then there is a transabdominal scan. If the fibroid is palpable parabdominally, then TAS can be done, and the transvaginal scan is where TVS. Fibroid is not palpable parabdominally, then TVS can be done. The pressure symptoms are, if the fibroid is located according to the location of fibroid anteriorly, urinary frequency, there is increased urinary frequency. Posteriorly, there is urinary retention and constipation. Laterally, it can press on ureter leading to polycythemia or hydroureter or hydronephros. TAS can be given to this information. And what is pseudomake syndrome? Just of it, where it is a fibroid or ovarian tumor other than fibroma or thecoma, Brennus tumor or granulosa cell tumor, or all associated with right-sided pleural effusion and ascites. This is called as Make syndrome. And the correction for this is, the first choice is iron tablets. If there is no response, then go for gonadotropin GnRH for 3 through 6 cycles plus iron tablets. And also check for infertility, rule out other causes. Semen analysis should be done for the partner, and endometrial carcinoma should also be seen. And also evaluate for endometrial carcinoma, because since fibroid is a hyperestrogenic condition, it can predispose to endometrial cancer, that is leiomyosarcoma. And for treatment purposes, patients are divided into two categories: submucosal fibroids and intramural subserosal. Coming to submucosal fibroids, the treatment of choice is myomectomy, remove fibroid, such as in submucous type 0, type 1 fibroid, submucous type 2 fibroid, or if size of fibroid is more than 5 centimeters. So the submucous type 0, type 1 fibroid, we opt hysteroscopic myomectomy, and submucous type 2 fibroid, and if the fibroid size is more than 5 centimeters, we go for laparoscopic or abdominal myomectomy. And coming to intramural fibroids or subserosal fibroids, there is medical management. We use first line drugs, second line drugs, and we use progesterone decreasing drugs. The first line drugs are nothing but drugs which support the endometrium are administered. That is, they will decrease the bleeding but will not decrease the size of fibroids, such as OCPs, estrogen and progesterone compositions, and progesterone alone, and also an additional drug, tranexamic acid. The second line drugs are the ones which decrease the size of fibroid as well as the bleeding. We use anti-estrogenic drugs such as GnRH agonists like leuprolide acetate, and GnRH antagonists such as ilagolex. Alternatively, we can also use danazole and letrozole. Progesterone decreasing drugs can also be used, such as mifepristone and ulipristal. And another treatment of choice is uterine artery embolization. It is a preferred second-line management in situations where oral GnRH antagonist is not available. The principle used here is uterus is supplied by uterine artery, which is a branch of internal iliac artery. So by decreasing the blood supply to the uterus, blood supply to the fibroid can also be decreased subsequently, as a result of which size of fibroid decreases and symptoms are relieved. The procedure is simple. It is done via femoral artery. The contralateral uterine artery is being embolized using polyvinyl alcohol. This is a femoral artery. We are introducing a catheter, angiographic catheter. We are simply blocking the contralateral uterine artery, thereby decreasing the blood supply of the uterus as well as the fibroid. The ideal candidate should have all the characteristics such as heavy menstrual bleeding, premenopausal, no desire for future fertility. And absolute contraindications of this include pregnancy, PID, malignancy, symptomatic fibroid, and decides future pregnancy. And the relative contraindications are, these are the absolute, and the relative are mainly postmenopausal female, as I've discussed. Ideal should be premenopausal. And after menopause, size of fibroid decreases, increased chance of leiomyosarcoma. And in pedunculated or pedunculated submucous or pedunculated subserous fibroids is with a narrow stalk. The stalks may get necrosed and such fibroids may detach and lodge into the peritoneal cavity. So the side effects of these are: most common post-procedural pelvic pain. Second most common side effect is vaginal discharge. Coming to third line of management of heavy menstrual bleeding is where focused ultrasound surgery, that is HIFU, high intensity focused ultrasound, or MRGFUS, magnetic resonance focused ultrasound. So coming to this, the patient lies supine. Patient lies in supine position. The USG rays are focused onto the tumor, and this tumor undergoes, this USG rays makes the tumor undergo coagulative necrosis of the fibroid. And even the same is done on MRI machine. Source of radiation is inside the machine. Here also there is coagulating necrosis of the fibroid. The indications are only the number of fibroids is less than 3, size of fibroid is less than 10, and fibroid not calcified. All the three conditions must be fulfilled. And coming to the third line of management is endometrial ablation. It is of no much use, but except with the fibroid with heavy menstrual bleeding with associated bleeding disorder. And the hysterectomy is again of two types, mainly vaginal hysterectomy and there is abdominal hysterectomy. Vaginal is again divided into two, that is descent and non-descent vaginal hysterectomy, often done in uterus with fibroid less than 12 week size and can be done up to 16 week size, that is 12 to 16 weeks. The advantages are, it is very less painful and it's cosmetically very much better, less chances of incisional hernia, less chance of paralytic ileus. Abdominal hysterectomy can be further divided into total abdominal hysterectomy or laparoscopic abdominal hysterectomy. So coming to the briefing of the steps of vaginal hysterectomy, there are a total of 12 steps. Step 1, we do hydrodissection. 1 ml adrenaline is given with 2 ml of saline, normal saline, infiltrate over the cervix and vagina at angle of 15 to 30. Step 2 is incision to be given at the cervicovaginal junction. Step 3 is pubocervical fibers are cut using a sharp scissors. Step 4 is where one sharp dissection is done. It is followed by blunt dissection. Step 4 is blunt dissection using fingers to create space. And then step 5 is clamping the ligaments. There are several techniques. One technique is by clamping the uterosacral ligament on one side, cutting and ligating it, where Vicryl 1-0 suture is used. And step 6 is where pouch of Douglas is open so that space is created. And using Kocher's 4 steps, the pouch is held and with the help of scissors the pouch is opened. Then moving on to the contralateral uterosacral ligament ligation, the same steps. Step 7 is where uterine artery ligation, and step 8 is deliver the uterus. The uterus is cut in the center and all the fibroids are enucleated. The fibrous pseudocapsule is then removed. Step 9, once the fibroid is removed, a last clamp is put at the cornual end of the uterus. It is then cut and ligated. The same procedure is done on the other side. At the cornual end, the round ligament, ovarian ligament, and the fallopian tube is present. And coming to the last step, the uterus is then removed, vault of vagina is sutured, and step 12, saline irrigation is done to look for fresh bleeding. The other techniques opted can be, another technique is used by opening the pouch of Douglas first, while some open the uterovesical pouch first. And the instruments used here are Foley's catheter or metal catheter, and we also use Sims double splayed speculum, Sims speculum. And we also use anterior vaginal wall retractor, and we also use Wilselem forceps tenaculum. It is used to hold the anterior lip of cervix, and blade number 22 and BP handle number 4. This is used to make an incision at the cervicovaginal junction as discussed. And then we use Deaver's retractor. It is used to retract the posterior wall, just the basic point. Landon's retractor used to push the bladder up, it is L-shaped Landon vaginal retractor. L for L-shaped Landon. And Koch's forceps used to hold the pouch of Douglas. And then Koch's hemostatic forceps and to cut open the pouch of Douglas, and clamps, so straight or curved clamps used to clamp the uterosacral and McIntrott ligament complex pedicle. So this is the Dugan's intestinal occlusion clamp and Peary's crushing clamp. And Wickrell 10 suture material, most commonly used for hysterectomies. And the needle holders, the blades have a groove to hold the needle. These are the needle holders. Okay, and there is Alice forceps to hold any hard tissues. Alice tissue forceps. And other surgical instruments are Doan's retractor and Zerni's retractor and Cheadle forceps. This is the Cheadle forceps. Coming to abdominal hysterectomy, although the principle of both vaginal and abdominal are same, there is a difference in the sequence of clamping. The first clamp is where at the cornal angle enclosing the round ligament, ovarian and fallopian tube. The second clamp is given at the level of internal os where the uterine artery is clamped. Third clamp is at the uterosacral and cardinal ligament. Fourth clamp at the angles of vagina. And this is called as uterosacral suspension or wall suspension. And coming to briefing of the steps, step 1 is where there is incision is given called as funnel style incision, where all the layers of the skin, the skin, subcutaneous tissue, the rectus sheath and all the muscles are cut. And after the rectus sheath is being cut, the muscles are separated using hands. Once this is done, peritoneum is cut and the uterus is delivered out. Step 2, first clamp is given at the cornual angle as discussed. Step 3, the peritoneum is cut in the level of uterovesical pouch. Step 4, the bladder is pushed downward and uterine artery is clamped. And step 5, clamping the uterosacral and cardinal ligament. Same process is repeated on the other side. Once this is done, a clamp is used to hold the vagina and to clamp the descending cervicovaginal artery, and these are placed at the angle of vagina. Step 6, the uterus is removed. Step 7, when the uterosacral ligament was ligated, a long thread was left behind on both sides so that ligament can be attached to the angles of the wall. Step 8, vault is repaired.